Wonderful, James. Well, hey, thanks for coming back. And well, this is going to be the last of the MACRA MIPS topic, at least for a little while.
Yeah, it's a it's a
Hopefully you learn
lot
a
of
little bit. It's a
yeah,
lot.
it's quite a bit of work to put it together just because we want to give you guys the most accurate information, but the problem is that if we're too hyper specific, then we're not really paying attention to everybody else. So it's a tricky scenario. So everything is always going to be it depends, but we can go for some generalities based on certain numbers that are out there in the industry.
Agree. We'll give it one more minute, Jose.
Perfect.
We're gonna bypass the trivia today and just dive
Sounds
into it.
good.
We'll look to do it
Well,
next week.
either that or you can do the trivia right now, and then
Yeah, you know what? Let's do it right now. I got it. I got
if
one.
you've got one.
I got one lined up in the chamber. We got enough in here. Oh, Don's in here. There we go. I was looking for her. Hey, Don. Just in time. Let me go ahead and share a screen with you guys. Jose, let me know if you can see. Might take a sec.
Yep, there we go.
Cool. So, guys, for those of you that are just joining in, appreciate you being on today's session. As always, we do a little just trivia question from last week's presentation. And last week's presentation, we talked a little bit about MIPS and the performance category. So, question today is, which of the following is not one of the MIPS performance categories discussed in the webinar? Is it
Oh,
A, quality, B, resource use, C, meaningful use, or D, clinical practice improvement activities?
sorry.
We'll give it 30 seconds. Don, I see Don's, Don's on it. Please feel free, anybody that's in here, please feel free to throw an answer. Don't let Don be the only one.
Don't let Dawn intimidate you guys.
She said she knows she's right too. All right. So again, the question was, which of the following is not one of the MIPS performance categories discussed in the webinar? Is it A, quality, B, resource use, C, meaningful use, D, clinical practice improvement activities? Don, and James, you are correct. The correct answer is meaningful use. It is not a part of the MIPS
Because Dawn
performance
is right.
categories. Because Don is right. I love that. Good guy. Hey, good job, guys. Again, we just do this to get the blood flowing, and obviously, you guys were on last week's webinar, so you did pay attention. Good job. So let's go ahead and dive into the presentation piece. Let me go ahead and get that up.
So while Ray's getting that up and everything, and we're going to be punching it pretty quick in the face just because we're trying to we're trying to play with the schedules a little bit, trying to see if it's easier to just do a 25-minute like today or like a little bit more of a longer one. So
Yeah.
feedback's definitely going to be appreciated. But today we're going to be diving into a little bit more on the specific pieces. What are some measures that we can use in MACRA and MIPS, and is it even worth it for us? Because some of the things we're already doing, some of the things we got to train the providers to do, some of these things administratively we can do. I mean, there's 90 different measures, so we kind of picked a few, try to play with the mathematics and see if the juice is worth the squeeze. The answer is always going to be it depends, but we wanted to see if you're interested and you haven't been participating or you haven't been seeing the results, then maybe these are different pieces that you can take a look at. So we've gone through trouble highlighting a few so we can touch those and touch a little bit on the formula if you don't know how the MACRA MIPS formula is set up. And yeah, so go for it, Ray.
Yeah, well, Jose, I appreciate that, and again, for those of you that are joining here that for the first time, appreciate you guys joining in. My name is Ray. I will be your host today for today's session. And as Jose mentioned, we are going to be talking about MACRA and MIPS, maximizing value or just added burden. This is part 3 of this webinar series for this particular topic. For those of you that might have missed the first 2, we are going to be getting those up on YouTube, and we will be sending out links after this webinar so that you can look back on those. Again, I'm joined by my co-host, Jose. Jose. Jose has 17 years of experience in the healthcare industry with consulting, and he also currently runs a telehealth clinic, telehealth mental health clinic. Jose, anything that I'm missing?
Nope, that's it.
Awesome. And actually, I did miss something. So just real fast, one of the reasons why we're doing these webinars, obviously to bring value to you guys, but also I want to shed some light on our EPICompliance event, which is an in-person event that we hold every year. We talk about compliance and innovation, and we also offer a training course there. It's called the HIPAA Security Officer CHSO training course, and that is something that Jose has instructed as well as myself. And this is a course that we are going to be offering here online very soon. Please stay tuned. I know we have a couple people in this audience that have taken the training in person as well. So we appreciate your support. And as I mentioned, this is a course that we'll be offering online here very soon. So please stay tuned. Jose, anything to add to that?
No, not at all. Not at all.
Awesome. Well, let's go ahead and dive into it, right? So,
okay, so this is the example that CMS put on their website. So if you ever look up, hey, what is MACRA MIPS? This is pretty much the first thing straight from CMS.gov. I hate this thing. I love it and I hate it. And here's why. It makes, I don't know about everybody else, but it looks to me very complex at a glance. And there's a lot of details and not a lot of details all at the same time. Like there's a lot of information on this thing, but it's not telling me how. So like, okay, great. I've got a high weight activity. What does that even mean? I've got a medium weight activity. What does that even mean? Where's the list of these activities? So it's something to where you really gotta take a look and see what is worth what. And sometimes it's not even worth doing some of the high list activities. But like I said, we've gone through the 90 different measures that are available to practices. And we picked out a few that you can probably do if you've been involved with healthcare since meaningful use. And there's a few of them that we highlighted just because they're kind of interesting and may offer different opportunities for a practice if they're looking to expand their market share or move into a market that may be underserved, but there's opportunity for maximization on revenue per service.
So Jose, these measures, it doesn't, or at least when I was doing some research on the CMS, I couldn't find a whole lot on these measures, strangely enough.
Yeah, so finding the specific measures is a little bit trickier than normal. So like I said, there's some things here that I found them through a couple different other resources that I use as a consultant. So I was able to just go and review them and pull some of the ones that I thought were easy and then some of the ones I thought were interesting. So let's start with the medium measures because notice how there's nothing easy measures. I'm not going to say anything about that other than they've pretty much only given you these 2 types, right? So some of these things, and on the screen right now, you have a list of a few of them. I'm not even going to read them all. You can read them all while we're talking, but realistically, some of these things you're doing already. If you're, well, I take that back. If you're in a primary care setting or if you're in a setting that takes a look at a lot of different independent systems of the body, then you're already doing these. However, if you're a highly specialized subspecialty of medicine, then yeah, you're probably not going to be doing this stuff. A neurologist is not going to be asking about diabetic screening. They don't care. You know what I mean? Like an orthopedic surgeon is probably not going to be utilizing group visits for opioid use disorders. Why? Because they don't want to probably put in the fact that some of these patients are addicted to opiates because they prescribe them after surgery. Like, so there's some things that just don't really track with business models, but we want to take a look at some of the ones that are a little bit easier. If you're not doing any form of telehealth, it's 2024. Were you around during COVID? Like, if you're not doing any telehealth, is an easy way to increase bandwidth, increase visit volume, patient volume with very, very little cost. You can do nurse visits, you can do chronic care management visits, you can do DME training videos. You can do all kinds of stuff with it. So it's absolutely crucial to have telehealth in some way, shape, or form in your practice for those that are on Medicare and those that are without Medicare. Because keep in mind, MIPS doesn't matter if you're not if these aren't Medicare patients. So if this is a Blue Cross patient, doesn't matter. If it's a Humana patient, doesn't matter. So if you're a practice that has less than 35% Medicare, participating in this may not be worth it, depending on how your providers work. Some of the things that are easy that you've been doing probably since ICD-10, especially, but meaning all the way back to meaningful use, is smoking cessation. If your patient is smoking cigarettes, are you talking to them about stopping? If your patient has high blood pressure, if your patient has diabetes, are you talking to them about ways that they can reduce those issues?
Alcohol use.
Like, it's one of those deals where you got to take a look at it all. Now, I did put in there the rural health clinic, the number 4, and I thought this one was interesting because if you know where to look on different state and federal websites, you can find out whether you are in a rural health area, which will allow for you to, one, bring in providers with limited licenses. So basically, providers that maybe are close to retiring and didn't want a full license, or providers that went to school outside of the US. And so it's a probationary license for them. But you can also get paid more if you're on a Medicaid platform.
Mm.
So if you're in a rural health area, all of a sudden Medicaid pays you closer to Medicare rather than, third of Medicare. So so it makes it a little bit more viable then to deal with your Medicare Medicaid combos, or or working with different hospitals or different nursing homes because they're high Medicaid. So you really want to take a look at what are we doing and how are we doing it. Remember, this is for Medicare. So what does that mean? That means you got patient families can be involved with this. Some of the easy ones here, believe on the
I left
on
one of
number
them
two,
out. It was the EHR,
yeah, the EHR, a
enhancing
lot
your
of the
EHR
EHRs that are on
systems.
the market now, they are set up with CMS to
Mm.
so that way they can grab data straight from there. So some of this stuff makes it a little bit easier. When you're looking at the patient experience information, some of that stuff is really easy to do because you can do that on the administrative side. Now, this also requires a shift to do the administrative stuff. It's going to require a shift to a little bit more of a making sure that the patient has a positive experience in healthcare, which is an odd thing in the US, interestingly enough. I've been in the industry for quite some time. I mean, I'm even a patient in some offices.
Right.
It's amazing to me how many times I walk into an office, or I'm talking to a patient, or talking to an employee of a practice, and they're grumpy. I go in and I'm not necessarily grumpy, but I can be in the best of moods. But if that first person, that first contact is not extremely cheerful or bubbly, the whole thing goes downhill. So there's certain things that you can do to help alleviate that personality and allow for that person to be their normal self, or maybe we don't have the right person in that front desk position. So it's something where we really, as administrators, we want to take a look and see what can we do to maximize some of these pieces so we can maximize our revenue and thus our profits. Cool, let's go to some of the high ones.
Yeah. So, what's the difference between the two? I guess, and obviously there's a medium and a high, but
So high, if you go
What's
back to the formula, the high is worth
that's worth
I
a more
believe
a bigger,
it's worth
larger
more points.
was it 60
No,
points,
no, it
I
was
think, or
60 total
60
on the
total? You're right.
example.
Yes,
But it was the 60 of available out of the, I think it's 83 maximum per visit,
correct.
which is a random number considering it's hard for you to get to 83, but with the formulas and all that stuff. So the idea would be that we want to see which ones we can use so that way we can set some stuff up so we can progress, right? One of them,
Right.
there's quite a few high measures for behavioral and mental health because a lot of the behavioral and mental health conditions can be treated rather easily if they're addressed quickly and aggressively and then tapered off so that way they don't lead to other ways, right? So you have the old joke of, hey, I'm depressed because I eat and I eat because I'm depressed. Well, that probably means your depression is causing secondary issues that may be leading to hospitalizations, maybe
Mm,
leading to diabetes complications, maybe leading to hypertension or high blood pressure complications. So there's a lot of different things that you can do on the low end side at the time of an evaluation or a visit with your patients, and it'll track. So, if you're dealing with if you're a rheumatologist, for example, where you're dealing with a lot of chronic care management, right? Documenting those and using telehealth, all of a sudden, boom, boom, you picked up two high measures for these patients that are essentially nurse visits
mm,
that aren't costing you as much because the provider isn't necessarily doing it. Your RN is doing it, or maybe your MA is doing it, or maybe your dietitian is doing it, or you know what I mean? Like, so there's a lot of different ways to play with this. And for it always depends, the profitability always depends on your specific practice, but you want to take a look and see what are the rules of the game so that way you can see if it's even worth playing, right? The
makes
opioid
sense.
use disorder. So I put this one down because in a lot of states, the DEA has alleviated and the DEA at the federal level has alleviated the ability for providers to prescribe buprenorphine, also known as Suboxone, for opioid use disorder. Now, believe it or not, just setting up your provider as an opioid use disorder provider, being able to prescribe Suboxone, which is CE classes right there, all of a sudden, boom, those are measures right there that you're hitting on the high end. You don't have to take any of those patients, but if your provider is able to do so, then you're hitting some of these high measures. So it's one of those things where we want to go and just check boxes.
Mm,
You know what I mean? That's what we're trying to do is check as many of these boxes as we can within our current protocol and operating procedures, right? Enhancing patient portals. So if we're dealing with a lot of hypertension patients, if we're dealing with a lot of orthopedic patients, where we want to follow up with the patients after surgeries, make sure they're not having complications, see how their PT is going. This is a simple MA call through, you can use telehealth. It can be a video call. You know what I mean? It can be a nurse's visit. These are what those 99212s are for. Boom, 15-minute. Boom, 15-minute. Boom, 15-minute. Yeah, it pays $50 from Medicare, but it's also allowing you to hit some of these measures on the back end. So we're increasing different volumes. We're increasing volumes of visits. We're utilizing our fixed cost and our variable cost of the location and the devices, plus the MA or RN that's already on staff. So it's something to where we can really just move the needle a little bit here and there. But moving a little bit here and there for every patient that you have that's Medicare, let's say a provider has a role of 2,000 active patients is more or less full time, right? Industry standard. So you're looking at, let's say, 500 of those patients are Medicare. And let's say 100 of those patients were doing follow up visits on the chronic care side of things. I mean, you're talking another $5,000 a month for one visit, and MA isn't going to cost you $5,000 a month. You can
right.
have an RN just do that by herself, and that's all she does, and that'll pay for itself. So it's really one of those things where we want to take a look and see what fits within our business model and whether our business model is even viable moving forward for the next 20 years, even though it's been viable for the last 20, right? So let's keep on going. I know we're reaching
We
towards the
sort
end,
of
but like we're talking
we've
about,
already
yes, you,
touched on that for the most part. We could talk
yep,
about the maximum adjustments graph.
yep. So is the juice worth the squeeze?
Right.
I mean, I don't know. I don't know where all of our viewers are from in the US, but I'm seeing every day, every practice I talk to, they're having the conversation of, is it even worth taking insurances? I mean, what if you're looking at this maximum adjustment, which there's all kinds of cuts talking about in Congress, but if we just base it off this graph, I can deal with a 9% cut if I don't have to do a bunch of paperwork. But if I'm already doing the work and all I have to do is a tweak on documentation, I can get 9% bonus. I mean, again, let's say we've got 100 patients, a 9% bonus on $100 visit. I mean, you're looking at $1,000 more or less, or just under $1,000 for the month. Like I can do a lot with that.
Yeah,
I
it's
can
not
be
bad.
that's my rent at the office or part of the rent at the office, or that's my IT bill. Like there's a lot of different things that we as a practice can do with $1,000 extra a month for the same level of work. But it's really just addressing. And remember that it's up to 9%. So you could be seeing a 4% bonus. You could be seeing a 7% bonus. You could be seeing a 1% bonus. If I'm seeing a 1% bonus, it's not worth doing it. I'm going to be honest with you. Not for me, anyways. If I'm
Right.
looking at it, a 1% bonus is just not big enough. But if I'm already doing the work for a 7 to 9%, then yeah, I'm probably going to. Um, and there are some specialties where this makes no sense at all. Absolutely. Um,
What specialties would you
Neurology.
say that really doesn't
Go ahead.
apply? What specialties would you say this does not apply whatsoever?
So,
I
I
guess
mean, there's specialties where it flat out doesn't apply in the respect of it doesn't matter whether you do it or
you're
not, they're
not
not going to
taking
change your payment,
right.
right? So then in those specialties automatically doesn't matter. So you're talking about your PTs, your OTs, your things like that. But when I'm looking at what I do in the practice, is it even worth it? I mean, I can see podiatry is only going to care about the diabetes because they're, at least in Florida, they have the scope of practice from tip of the toe to the hip,
Mm,
so they could do amputations. So diabetic amputations, dealing with wound care in the legs, that's big money for podiatrists here in Florida. So they'll care a little bit, but they're not going to go into they're not going to go into the mental health side, behavioral health side of this. So then
right.
they're cutting out a whole section that could be a bunch of high measures to get their points easier. If I'm a multi-specialty practice, it makes sense for me to do this because I'm already hitting all of these different areas and I can cause other visits within the practice to the different specialties. If I'm a primary care practice, I'm going to take a look and see what kind of things are we doing now and what kind of things do we have space to do. Maybe it makes sense to talk to a psychiatrist, psychologist, a psych nurse practitioner, and bring them into the office. Have them work on my office 1 day a week, so they can do some of this stuff. So that way we can integrate that specialty into the practice and get the points that way. If maybe I'll take a look, see if my address is in an area where, hey, I have got a lot of M&M, Medicare, Medicaid.
Mm.
So then maybe I want to actually capture a higher Medicaid percentage.
Where
So it's something to where what's my payer mix look like?
I think it
That
boils down
makes
to, would you say, patient population, and obviously
so first
the
it's
measures are important as well.
so I would say it's a seesaw of what's my payer mix and then what's my business model.
Right.
If they clash, it's not going to work. If I've got a payer mix of 35% Medicare or more, then I need to address whether we're going to do MACRA and participate in the MACRA program in any of its formats. Because 35% can hurt if you're losing 10%, because then you're having the conversation of, do we even bother taking Medicare at all?
No, that's good info. I think that's where it starts. when you're
So I
when
mean,
it
you
comes
got
down
to
to
know your
making
numbers.
a decision
Yeah,
going with this or
yeah,
not.
and then I mean, you gotta, if you're gonna do it, you got to go for it. You can't half go for it. Half going for it just means more headaches for everyone involved. You either go for it or you don't.
No,
So
good point.
that's, I mean, that's kind of what we're looking at. Um, if you've got any specific questions, please feel free, reach out to us. We're more than happy to help you guys out in any way that we can. Let us know, by the way, if you like the shorter truncated format, or if you like the little bit longer. We're going to be tweaking a few things, see what we can get more engagement and more I guess, retention throughout
Yeah.
the whole talk. So,
For I
you
was
got
gonna
anything to
say,
add, Ray?
yeah, so no, I appreciate everybody joining in, and like I said, we appreciate any feedback on these webinars, especially those of you that have been attending for some time now. And I always mention this, if you guys have any topics that you'd like to discuss, obviously healthcare related or compliance related, let us know. Always willing to talk or touch on that subject. This was
Great.
the
What's next week's?
Yeah, good question. So this is the conclusion of our, at least for the MACRA MIPS for a little while. But actually next week I'm going to be bringing on Jose is going to be on as well, and I'm bringing on a HR compliance officer. Her name is Leah Hebert, and she owns a HR human resources business, and she also is a I want to say she's partnered with EPICompliance, but she works in tandem with EPICompliance with her clients. And I want to be bringing her on. We're going to be sort of interviewing her about what she does, and then she also took our certified HIPAA security officer training as well. I do want her to give the audience a little bit of her experience with that. Um, but that's going to be next week's subject. We're going to be talking about some HR stuff. And then from there, Jose, you and we got to talk
Yeah.
because,
Yeah. I mean,
um,
I imagine we'll give HIPAA a little bit of a break. We'll probably give OIG. Maybe we take a look at some OIG stuff.
what does the audience want? What do you guys want to
Yeah.
see?
What are you guys
Somebody.
interested in?
All right, Don. It's going to be a two-part with her. This is going to be sort of the foundations of HR and compliance. And I think in April, we're going to reconnect with her again and kind of elaborate on that, whatever Don wants. I like James.
Don, you just gonna be a producer on the
That's too
show? Is that
funny.
what the plan is now
Yes.
then?
That's too funny. Well, hey, if like I said, you guys are going to be receiving correspondence from us, obviously for next week's webinar, as well as information on what we do here at EPICompliance and how we can help. Jose mentioned it earlier. If you guys have any questions, concerns, listen, no stupid questions, a stupid question here. We're here to help. Please feel free to reach out to us, and we'll take care of you from there. We'll open up for just a quick FAQ. If anybody has any questions, concerns from today's presentation, or perhaps another one that we've done, or maybe last week's, please chime in, and we'll go from there. I need James and Don on next week's webinar so I can
Right.
deal with the banter.
Yeah, I don't think we'll get anything done. It'll just be funny, which would be a good one. When's
Man.
April Fool's? Should we do it on the April
Yeah,
Fool's
right.
count?
We'll do a special April Fool's event.
Oh, it's a Monday this year.
Yeah,
Oh,
that's all
so
right. We can make do. And by the way, for those of you that are just joining in, we do these every Tuesday. So next week's webinar will be February 27th at the same time, 1:35 to 1:55 p.m. Eastern Standard. Well, Jose, it looks like we don't have any questions. So,
Perfect.
hey, I appreciate your time as always, everybody or everyone. I appreciate your guys' time as well. I hope you guys found some value in this series about MACRA and MIPS, and look forward to seeing you guys at next week's event. Stay tuned, and please look out for some correspondence that will be going out here this afternoon to register for that event. Thank you so much, guys. Jose, Don, James, we'll see you next week.
See you guys.
Take care, Jose. Bye.
Bye.
Sunshine.